Good afternoon, everybody. I'm really grateful to the organizers of a World Cancer Conference and the panelists. Uh, I'm working as a gastrointestinal tract sonologist since 1994, and I'm working as a in the tumor thrombus core biopsy since 2019. This is a single-blinded prospective study of the diagnostic accuracy of the ultrasonography in detecting primary gastrointestinal neoplastic lesions. These are the criteria I made to detect the lesions in the gastrointestinal tract, that is delayed emptying of the stomach, wall thickening, its sequentiality and change in layering patterns, that is a gut signature. Anatomically there are 4 layers, but sonographically there are 5 layers. Peristalsis and distensibility has to be seen on the real-time study, deformity to label the chronicity, and personally adder speck of the air in the wall. That is, when we were doing the barium studies, the barium used to adhere to the irregular surface of the ulcer crater, but in ultrasound, microbubbles adhere to the irregular surface of the ulcer crater, and ascites and pneumoperitoneum in malignant perforations. This is a normal gastroesophageal junction. This is a Ryle tube in the gastroesophageal junction. This is the malignancy of the gastric part of the gastroesophageal junction, and you can see here. Here you can see that there is a bright central ecogenic lumen. This is an eccentric wall thickening, and this is symmetrical wall thickening of the gastroesophageal junction. This is a adenocarcinoma. This is a malignancy of the gastric part of the gastroesophageal junction. You can see there is a protruding polypoidal growth seen arising from the malignant lesion of the gastroesophageal junction. This is a hypertrophic pyloric stenosis. This is a benign lesion in pediatric age groups. This is a tubercular gastritis. Here you can see the wall thickening. However, the gut signature is accentuated, and along with few lymph nodes around in the perigastric region. Gastroscopist took the biopsy from the endoscopy, and I took the biopsy from the perigastric lymph nodes, and both were positive for the COX. These are the gastric polyps. This is a sessile polyp, and this is the pedunculated polyp. This is gastric intramural benign tumor seen along the anterior wall. This is along the posterior wall with veil margins. This is again a benign tumor seen along the lesser curvature of the stomach. Here you can see it's a benign lesion seen along the lesser curvature of the stomach. It is protruding into the lumen, but otherwise the rest of the stomach shows normal gut signature and distensibility. Here you can see this mass lesion, polypoidal mass lesion. This is these are the cases referred by the gastroenterologist, and he found mass lesions along the posterior wall of the stomach, and I did the ultrasound, and this was a spring water cyst into the stomach, and this was the intramural pseudopancreatic cyst of the stomach. This is an acid gastritic. You can see the fluid filled wall of the stomach, and these are the some mucosal dissections causing leakage of the acid. This is chronic acid gastritis. This patient was mimicking like a malignancy, but when we took the biopsy, it was a chronic gastritis, and the history proved that she had a history of accidental acid ingestion. This is a chronic wall benign thickening of the outer layer of the stomach. Here you can see the video which is showing the benign outer wall, that is serosal layer of the stomach. This is the gastric bezoar. The floating mass lesions seen within the stomach, these are the bezoars. Then I'll move to the duodenum. This is a normal duodenum, stomach duodenum, second, third, and fourth part in front of spine and great vessels. This is an anatomical view of the normal duodenum. This is a dirty ascites seen in the perforations, and this is a pneumoperitoneum seen within the uh, malignant or benign perforations. This is a normal ampulla of Vater. This is second part of the duodenum. This is normal ampulla of Vater. This is lower end of the CBD. And here you can see the ampulla of Vater is normal, but it has been distended by the cholestatic cyst. These patients were referred by the gastroenterologist, and they found a mass at the ampulla of Vater, but negative for the malignancy on their biopsy. So they referred that case to me and found the ampulla of Vater was normal, but it was prolapse within the lumen of the second part due to the dilated CBD, and the column of the CBD was literally pushing the ampulla of Vater within the lumen of the second part of the duodenum. Here it is also a prolapse, but here the cause is impacted stomach in the ampulla of Vater. This is a eccentrically pushed lumen of the duodenum due to intramural hematoma. This 5 years old boy has a trivial trauma from the cycle, and he had a duodenal hematoma. This is also a duodenal hematoma, but here the cause is dengue fever. This is a duodenal hematoma. This is also a duodenal hematoma. Here the eccentrically pushed lumen. On endoscopy it was looking like this, and this was a hematoma. These are the duodenal polyps seen in between the second and third part of the duodenum with some calcifications within. This is a duodenal malignant lesion. Here the volume is increased. There is a loss of gut signature. There is no differentiation in the layering pattern. It's complete loss of gut signature. This is a malignancy of the ampulla of Vater with a double duct sign, that is a main pancreatic duct and common bile duct is dilated due to the mass of the ampulla of Vater. Here the mass of the ampulla of Vater is involving second part of the duodenum. This is a gastric malignant lesion seen along the antrum of the stomach, and see the mucosa is normal. It is submucosal malignancy which was not able to seen on the endoscopy. This is a gastric malignant lesions. There is a gross wall thickening along with loss of gut signature. This is also a gastric malignant lesion. This is a gastric malignant lesions seen along the body of the stomach. This is also body of the stomach. This is the duodenal outlet obstruction due to benign stricture. Here you can see the duodenum is smaller in size with closed lip pattern with a lot of food and fluid residue. This is a benign cause of the duodenal outlet obstruction, and here it is the malignant cause of the duodenal outlet obstruction. The mass is causing stricture at the postbulbar region of the duodenum. This is again a malignancy of the second part of the duodenum which is causing outlet obstruction. This is the intramural hematoma in the jejunal loop. Here you can see the defect causing the intramural hematoma. This is a small bowel polyps. Here you can see the polyp, and here you can see the polyp. It's bright, so it is adenomatous polyps. This one is a large bowel polyp seen along the ascending colon, and you can see there is a some kind of obstruction causing a, and on endoscopy it was showing like this, and it was removed by the use of polypectomy smear. This was adult terminal ileal intersusception, and the lead point is this polyp, adenomatous polyp. This was adenomatous polyps causing a adult terminal ileal intersusception. This was a CT scan image of the same patient, and he was having polyp seen along the terminal ileum causing a ileo-ileal intersusception. And this was his intraoperative image, having confirming that it is a polyp causing an intersusception. Here you can see there is a loss of gut signature and also the gradual narrowing, and here you can see the complete stricture seen in the terminal ileum, and you can see there is a loss of gut signature, complete loss of gut signature. This is a perforated malignancy of the rectum. Here you can see the the rectal perforation was around 4 mm and it was causing perirectal abscess formation. This was a malignant region of the rectum which was encroaching the urinary bladder wall. Here you can see the bladder wall is encroached. I used to perform the ultrasound guided biopsy of the malignant lesions without entering the lumen. You can puncture a normal bowel multiple times, but if you puncture lumen of the abnormal bowel, it will cause a fistula. So you need to go tangential with the wall and not entering, and the ultimate care should be taken to not to enter the lumen to avoid the fistula. This is the ultrasound guided core biopsy of the bowel wall tumor without entering the lumen. This is ultrasound guided core biopsy. Then I used to, right now I have completed one PhD in diagnostic radiology, and right now I registered myself for the ultrasound interventional PhD in the interventional radiology. My topic is ultrasound guided core biopsy of the tumor thrombus. This patient is having portal vein tumor thrombus, and I have taken the core biopsy of the portal vein tumor thrombus. This is ultrasound guided core biopsy of the inferior vena cava. You can see there is a mass seen along the retroperitoneum. It is encroaching. This is abdominal aorta, this is IVC, and the tumor has entered into the lumen of the IVC, and I took the biopsy of this IVC tumor thrombus. And the care has to be taken that I should not hit the luminal surface of the tumor thrombus to avoid the micro and macro embolization. This is again a dangerous case. I took the biopsy ultrasound guided, the right main pulmonary artery tumor thrombus, and I did it under ultrasound guidance. And at the time my needle was very close to the heart. It was a tumor thrombus in the right main pulmonary artery. This is an intraoperative sonography, and you can see there is a pancreatic lesions. I put a probe on the pancreas directly. And so you can, for pancreas, endoscopic ultrasound and intraoperative ultrasound are the gold standards. Here you can see the lesions. This is the normal duodenum, and this lesion in the tail. These are the lesions in the body. You can see what either you can see either what you know or what you can imagine. My conclusion is some more efforts taken during all routine sonography exams can help to primary either undiagnosed gastrointestinal neoplastic lesions. Sonography is an effective, useful, non-invasive method of investigating benign and malignant neoplastic lesions of the gastrointestinal tract. Thank you very much.